يعطيكم ألف عافية. اليوم هو يوم مميز من كلية طب الأسنان اللي هي أجمل الكليات. حقيقة صارت ترند، يعني صار هذا اللفظ اللي بيقوله أستاذنا العميد أستاذ الدكتور وسام الجبان مشكورا اللي عم يتيح النشاطات. صار ترند عنا هو إنه كلية طب الأسنان هي أجمل الكليات. اليوم هو يوم علمي مميز مع جامعة أولموك من التشيك. اليوم معنا الاستاذ الدكتور دانييل تشيرني، هو استاذ مساعد في جامعه اولموك من التشيك واستاذ مساعد سابق في جامعه تشارلز في التشيك، وهو رئيس اكاديميه التجميل في جمهوريه التشيك ورئيس تحرير المجله التشيكيه لطب الاسنان. هو مؤسس مساعد في معهد HDVI في براغ التشيك، ومؤلف ل 35 مقال منشور في كبرى المجلات العالميه، ومؤلف مشارك في كتابين في طب الاسنان التجميلي والترميمي. من الجانب السوري نحن فخورين جدا بانه يكون معنا استاذنا وصديقي الخاص استاذنا الدكتور عمر حماده الغالي جدا والغني عن التعريف. استاذ الدكتور عمر حماده هو استاذ في قسم طب الفم الاورال ميديسن، حاصل على الدراسات العليا في جراحه الفم والوجه والفكين، ماجستير في الاورال ميديسن من جامعه دمشق، دكتوراه في الاورال ميديسن من جامعه نيوكاسل المملكه البريطانيه. دكتور عمر نحن كثير سعداء فيك. We are happy today that we are making a meeting, a scientific meeting between Olmouc University in Tchik and Damascus University. From Tchik, we have Professor Daniel Tchirni. He is a faculty member of Balaxy University Olmouc Tchik. He is an editorial board member in LKS Journal in Tchik. He is a Continuing Education Institute founder. He is an author of 35 articles in dental journals and a co-author in a chapter in dental books. He is lecturer in very scientific meeting or a lot of scientific meeting around the world. From Damascus University, we have Prof. Dr. Omar Hamadeh. He is a professor in oral medicine department. He has held his postgraduate from OMFS from Syria, Damascus University. He held the master degree also from Syria in oral medicine. He has the PhD from Newcastle University, England. He has several publications. He is one of the pioneers in publications in our university, and he is nowadays a co-author of several books. One of them is about how we handle patients inside the hospital, and the other is about oral medicine. Dr. Omar Hamadeh will greeting Dr. Daniel Tchirni. We are very happy to have you both today. Dr. Omar Hamadeh, you have maybe 10 minutes to start an overview in Arabic about the lecture today. We are very happy that you are with us today. The audience is yours, Dr. Omar.
Thank you very much, Dr. Anas. Hello, Dr. Dan Tchirni. I'm very proud actually to introduce you today for our student and our faculty members. First of all, just please give me a few minutes just to speak a little bit in brief about your presentation to our student in Arabic. شكرا كثير دكتور أنس. حقيقة الشكر موصول للأستاذ دكتور وسام الجبان حقيقة لهالفعالية. من وقت ما بلشت الكورونا حقيقة كمية كبيرة من المحاضرات القيمة، المحاضرين العالميين اللي قدرت جامعة دمشق تتواصل هي وياهم، نستفيد من هالمنصة لأنه نطلع طلابنا ونقدر نسوي تواصل ونفتح كونكشن معهم. حقيقة المحاضرة اليوم أنا دكتور دان تشيرني صحبتي معه قديمة، التقيت فيه عدة مرات، حقيقة فخور بمعرفته. الدكتور دان تشيرني هو من الليدرز بالاندودونتكس بجمهورية التشيك، هو رئيس تحرير أهم مجلة بالاندو بالتشيك، ومحاضر انترناشنال بعدة محافل دولية. الشيء الاساسي اللي راح يحكي عنه اليوم، نحن مثل ما بنعرف انا اسمحوا لي بس اكون ضيف على موضوع الاندو. الاساس بالمعاملات او اساس المعالجات نجاحها طبعا الجزء الاول لاختصاصي معالجه جذور الاسنان، المعالجه الجيده باتمام المعالجه اللبيه، لكن هي المعالجه بغض النظر قديش كانت الجوده تبعتها، وطبعا نعرف قد ايه بيتفانى اختصاصي الاندو لحتى يتم، بيجي دور الترميم اللاحق او دور الترميم التالي. وكثير من المعالجات اللبيه للاسف تفشل لاحقا نتيجه انه الترميم كان فيه خاطئ. طبعا نحن هون اساسا التراميم اللي موجوده عندنا على المعالجات اللبيه هي بتتراوح بين انه نحط فقط عباره عن حشوه محافظه الاوبريتيف فيلينج، او احيانا بنضطر نحط يلي فيه لسه عندنا كتله من السن نحط بوست اند كور، او ممكن نروح للفايبر بوست او لترميمات الانلي والاونلي وانتهاء بالوضع التيجان. فالدكتور دان تشيرني راح حقيقة عنده خبرة وعدة بيبر نشرها بمجال موضوع الادهيزيف وموضوع الفايبر بوست وعوامل الفشل فيها، فرح يتحفنا بهالمحاضرة تبعته هي شو الحلول، شو الامكانيات اللي ممكن تساعدنا بعملية الترميم للحفاظ على المعالجة اللبية التي انجزها اخصائي اللب. اوكي Dr. Dan, it's our pleasure actually to start your presentation and to give the solution about how to restore all the teeth which have been already treated endodontically and how to achieve the successful, high successful rate following the performing the endodontic treatment. The floor of you, and we are waiting for your, no doubt, nice presentation.
Well, thank you, Omar, for this nice introduction. I didn't understand much from the Arabic part, but I'm really happy to be here today and give lecture for my friends in Damascus, and hope you're going to enjoy the lecture as much as I enjoy my daily work. So thanks again for the invitation. Let me start with sharing my screen. I need to have approval for screen sharing, please. It says that I cannot share the screen.
You can share your screen. Just a second. Okay.
Yep.
You can, please try it again.
Yes, here okay. I am. Share. And here we go. So my lecture today is called Critical Tools to Achieve Successful Adhesive Post-Endodontic Treatment. Now, the lecture sums up what I have been doing for past approximately 15 years. And it is quite a topic which I invested a lot of time. It is a topic that have been included in my PhD completing, and something that I've been lecturing around the world. I would be much happier to be over in Damascus and not to give lecture from a distance, and I'm truly sorry for what's happening over in your country. I hope that one day it'll be much better. And unfortunately, this year is even more complicated with this little thing traveling around the globe. So let's hope for the better and enjoy what we have while we have it. As already mentioned, I'm part of the medical school in Palatsky University. I also work for about 20 years with Dr. Munajed, who's been lecturing just a week or two ago. And together we've started some other projects too that try to educate the folks around Czech Republic and the globe, whoever was listening. I'm happy to be also the president of Czech Endodontic Society, and as such, I'm sending greetings to my endodontic friends in Syria, and hope that we can continue having nice relationships in the future. When I was dentally born, it was amalgam age. This was just before the millennium, 1998. And at that time, adhesive work was not much big of a deal in this country. And so I did a lot of amalgam work, classic manual endodontics. However, soon after that, we turned into adhesive age. And the adhesive age has made my life much more colorful, I would say. I've been doing minimally invasive dentistry, trying to hide the defect we leave out. I've been investing a lot of time in vital pulp therapy, trying to preserve vitality of the tooth. So I'm not a traditional endodontist in terms of killing every tooth that should be treated. And I've been also enjoying the cases where my endodontic skills would be able to preserve vitality of those immature teeth. And following some of these cases for 10, 12, 13 years made me quite happy when you see the results of your work. And on the other parts of my work, I, of course, do a classic endo, mostly retreatments, I would say. About 350 cases per year. I do retreatments on all the possible materials put in. And we've invested a lot of time in non-surgical retreatment cases where using modern technology, MTA, and then the restorative work of Dr. Munajed, we've been dealing with some very difficult cases. Some cases I've even made more difficult myself, not knowing something that I know today, like this lady here who I stripped personally this tooth, and then I had to deal with it. But it's 8 years down the road, and I'm still happy to see her in my office, still having that tooth present. And the other part, more technical of my work, I've been dealing with what kind of files and what kind of preparation design should we use in order to achieve the best result and not to damage the tooth too much, because we know that there's a balance between what damage you do and how clean can you make it. I've been happy to have these mentors of mine, which the first and very important one, Yesi Sedelmaier, unfortunately passed away last year. However, he was one of the folks that he makes everybody comfortable when he is teaching, and I learned a lot from him. In endodontics, I had these, and I still have these two mentors, one on the technological issues, which is Steve Buchanan, and one on the biological issues, which is Domenico Ricucci. And I know that Domenico has been giving a lecture on Thursday for you. And he's a great friend of mine. We visit each other in Italy and Czech Republic. And he made me think a lot about what we do. And my work is, however, a lot about resin composite. I'm an endodontist, but I'm sort of an endorestodontist. I do a lot of direct composite work. So on the scale of technology, biology, I'm the third leg. I'm the one talking a lot about adhesion and how to restore things. And for that, I've been learning from the masters like Lorenzo Vanini, Francesco Mangani, Pascal Magnier, Gianfranco Politano, or Camillo D'Arcangelo. All of these fine gentlemen have given me something out of what they know, which made me the endo-restodontist, I would say today. I took the post-endo challenge and tried to accomplish preservation of teeth that have been previously endodontically treated on a scale that would not make much difference between vital and non-vital teeth. Now, of course, we're not there yet. If in the vital teeth our possibility to preserve the tooth scales up to about 99%, in endodontics, we're now about 96 to 97% on a primary endo. It's not bad. It's actually very good from the perspective of past 50 years. However, we want to go even better. And on that, I need somebody to cooperate in the prosthodontic. And that's Dr. Munajed, who's invited me or recommended myself for your lecture as well. We go together for about 25 years. We've been working in the same practice for nearly 20 years. And we give sometimes lecture together, though it is sometimes quite difficult to do. We also organize meetings like the Dental Summit, which we've been happy and honored to invite Dr. Hamadak to 2 years ago. And so to my work, in 2006, there's been a concept 1.0. 2006 and before, we had this concept where endodontists would only make a root canal treatment and everything else would be done by the prosthodontist. It wasn't bad, but it was much worse than what we do today. Some of the cases are still surviving. However, in general, there's been lots of issues we've had. And so we abandoned this topic because we did not want to see these cases. We did not want to see failure of endodontics and a crown based on the endorestorative problem. And so we adopted concept 2.0, which means endodontist takes the tooth from the beginning to the point where there's not only the root canal treatment, but also the buildup. So the prosthodontics takes only abutment tooth already to be covered, rather than going inside the roots, which is quite difficult to do for prosthodontist. And so we've created this workflow where prosthodontist begins in the upper right corner with the treatment plan. Then we follow the prophylactic plan. We do all the scaling, oral hygiene. We insert implants. We do perio treatment if necessary. And then the endodontist jumps in with direct restorative procedures, with endodontics, with vital part therapy, with retreatments, and prepares these abutment teeth, going back to the prosthodontist to make the final restorations. And of course, this workflow can have minor adjustments. However, in general, it means that somebody who's planning the work is also the finishing the work, whereas in between, there's everybody doing their own specialty and their own expertise. And on that scale, what we've created is something quite, I'd say, known today as a root to crown concept, where we went from the left, from a case of a great damage to tissue, great damage to root canal space, a big invasion into the dentin, and we moved the cases to the right, where we have made the endodontics finer, we have inserted smaller posts, we have used more adhesive technology, we have used microscopes to see inside, and we have scaled down the size of our crowns in order to keep more tissue and more of the tooth to preserve it for longer time. To start with, let me show you a first published clinical research we've done a couple of years ago. We have collected 300 older cases out of our totally about 700 anterior cases of endorestorative work. And we calculated our success. The data was in between 2008 and 2012, and all the cases have been completed in our practice, endo and restorative work together. And what we came down, which has been published in International Journal of Prosthodontics, is that out of these cases, we only lost 10 teeth. 10 teeth have been lost due to random reasons, which leaves a cumulative success rate 96.7%. Now, this is anterior cases where there's much more force to put away the post. So the adhesive work has been challenged much more than in the distal, where, of course, the forces are very different. Now, 96 or 97% in 9 years is as a result, which is very promising and is very different from some of the works published. We've analyzed, of course, all the cases and been happy to see that most of the cases lost have actually not been lost to the most classic failure, and this is debonding. We only had 3 debonded cases, whereas everything else was pretty much different reasons. So what is the philosophy we have? I think that this is important. We don't have time. This is like a 2-day course. However, what we'll try to point out on is the main topics that I deal with when doing this endoresto. Now, there's 4 major points to be stressed, and this is tissue preservation, replacing with similar, adhesion, and fail-safe concept. Tissue preservation is quite clear. We want to spare as much tissue as reasonable and safe. We don't want to preserve tissue that is already lost. We don't want to preserve carious tissue. However, we know that the more dentin, the more enamel we keep, the better the prognosis. Now, there's a big difference between leaving in carious dentin. We know that this is mechanically wrong. However, we don't want to destroy or whatever is not necessary. And for that, you can take a look closely and some of this anterior work, where you see that placing in the post or any actually endorestorative work, I never enlarge the space given. I only use the space given by the endo already. So I'm not using a standardized size of 2 millimeters post for each case. I only use the space that is actually given to me and guaranteed by the endo. This is very important, not only from the perspective of keeping more dentin, but also from the perspective of not creating stress collecting points in the root canal. The second concept that comes very handy is replacing each tissue with something physically similar, something with similar physical properties. So we know the anatomy out of this beautiful work of Panos Bazosa and Pascal Magnier. We have this analysis of how the dentin and enamel look like. We know their physical properties. So when replacing dentin, which has about 18 gigapascals of Young modules, we know that resin composite might be ranging from 13 to 20. So that's a good material to replace dentin. And on the other hand, we know that enamel is close to 100. And so using ceramics is much better than using something softer, something not as stiff as the ceramics. So instead of placing in very hard metallic substance inside this soft root, we actually try to put in something that is flexible the same way as the dentin is. So instead of leaving metal in a caries inside the dentin, I remove all the caries. I try to make a nice dentin structure and then add more composite to it. So we have a base structure, a core that handles very similarly dentin composite, no stronger, not softer than the dentin. And of course, then on the surface, we have natural enamel, and plastic cannot handle the same way as ceramics. So replacing with similar means inside the root, you want something more flexible, something a little softer. And then on the surface, you want to have that hard shell that protects the tooth and keeps this abutment structure together. And that does not matter whether it's a vital or non-vital case. As a matter of fact, we handle the same way vital and non-vital teeth. So if you look on those lower vital molars, they are finished with crowns, just like that non-vital premolar in the upper jaw. And it's the same thickness, it's the same kind of crown. A third philosophical issue is adhesion. I believe, and it is supported by literature, that all components of restoration should adhere one to each other. So instead of having several strong parts, but do not adhere to each other, I want to have a complex, glued together piece. And for that, I'll take an argument out of my favorite hobby, and that's automobilism. I've been riding some motorcycles and cars ever since I was a boy. In the past, you'd have this car where it was a bit stiff frame, an engine, and you could actually drive this thing here on the picture. It's been very easy. If you look at the same type of picture of modern car, this is something you cannot drive. This is just an image. This is just a computer image. It does not exist like this, because modern cars, unlike the old ones, only hold together when everything is in place. So you have everything bolted and glued together, and your car is then much more stiffer, much more stronger than the old ones. And this is exactly what I'm looking for as a dentist in today's restorative dentistry. I don't want to have a stiff piece and a soft piece and just somewhat lying next to each other. I want it all glued together and help each other, just like in a modern car, the technology. And the fourth principle is also very important. When placing something in people's mouth, it's a replacement part, and you never are able to replace 100% quality of the original structure. And so when my restoration fails, I don't want it to fail the tooth itself. I want it to fail safely. Means let's have it dislodged. That's okay, but let's not destroy the tooth underneath. So when a failure should be safe. Failure should not destroy the tooth or the bone around it. We've had this nice case, which started about 14 years ago. A young lady with already retreatment case came in, and we've restored that with one of the first fiber posts back then. And in about 7 years later, she came in. Her small child has knocked into her tooth and the crown broke. And I said, well, this is nearly hopeless. I mean, there's not much we can do. However, we needed to do something on that day. And so I disassembled the thing. I put in a new fiber post. And about 2 weeks time, when she was already supposed to go for implantation, extraction and implantation, she said, oh, the tooth is okay. Let's keep it. And this let's keep it is now for already 5 years. And so we're looking at a technology that not only allows us to restore, but also preserve whatever is underneath and gives us second and third chance to actually restore. There's lots of literature supporting this, that using composite rather than ceramics or metals is helping the roots to survive potential further trauma. There's been lots of papers stating that repairable failures are happening in the resin composite and fiber post restorations rather than in the cases where we've used ceramics or titanium or classic cast post. And I'm not the only one who's actually supporting this. There's already some years ago been put out the paper. This is a systemic review by Dentistry, and he's basically following very similar steps that I have described. And this is somewhat supportive because there's been some stand against the adhesive restorations of non-vital teeth. And I think that these have been quite wrong. To go to those technical, clinically relevant topics, those critical tools, let me start with explaining the whole process. We do have a case of a molar here where you need to start with isolation. You need to remove whatever is damaged, caries, broken, and then non-aggressively do the root canal retreatment, disinfect the root canal system. And then after you complete your endo, you need to start assembling back together the tooth. And that means you need to freshen up the dentin, remove this dentin that's been damaged by our endodontic rinses. We need to select the appropriate restorative type, what kind of post, or should we have a post at all. We need to isolate again, adhere to the root dentin, which is quite difficult part, insert bubble-free cement, some kind of resin composite, insert the post and recreate the abutment volume before we go on and put on the crown. Now, these steps have been very often overlooked. Endodontists did not care that much, and prosthodontists did not know how to handle the inside as well. So funny enough, a specialist have not had a great solution to this case, but great clinicals, great clinicians, great dentists that do everything have actually been better on this than the specialist work. So let's go step by step of these tools so we can explain what is important. Tissue reduction management is a whole big issue. We need to know how to excavate the caries, how to discriminate the caries from a sound dentin, have a full control of that, and practicing classic direct restorative work is helping a lot because you just do the repetition all the time. I have restored probably about 20,000 teeth adhesively in my life. And that gives you a lot of perspective on how to remove caries and keep whatever should be kept in. A lot of adhesive training as well helped because I've been doing this on a daily basis. I do a lot of endo, but then about half of my work, I do adhesives. And this is important because normally endodontists do not have this kind of training. For me, this was a daily routine. And a third part, you think about how much dentin you need to remove from the inside in order to get to the infection down in the root canal. And so you're thinking about the files. Isn't the file too aggressive when you're using something too conical? If you're using something too small, then you may be leaving bacteria inside. And there's been papers explaining how the canal taper affect root stresses. I recommend you for reading this Rundquist from International Endodontic Journal from 2006, already describing how important it is to think about the taper of your instrument. We're happy today with the technology we have that we can access these quite complex root systems like this second molar, where you see the S curve and you can imagine how it goes in the 3D as well. And yet I can perform such treatment through a quite minor injury to the clinical crown. And this is due to the technology we have. And of course, restoring a small defect is a different story than restoring a large one. We do have these micro access preparations when it is necessary. Now, don't get me wrong, I'm not a friend of some ninja access. I do like to be conservative, but I hate to be foolish. This tooth has been crowned about 2 months prior the patient developing a pulpitis. And I had to perform root canal treatment through this nice fine crown. So I took the smallest possible access cavity, allowing me to complete successfully the full endo. So I had a full control. Now, of course, this must be done by a microscope, well, with a microscope, not by, but by, it was done by me with a microscope at my hand. However, the treatment then takes 3 hours instead of 90 minutes as usual to complete, including the restoration. So the first thing in tissue reduction management is root canal instrumentation, your file taper and shank diameter. You want to only use the files that allow you not to destroy the tooth much more. And lucky enough, there's been technology available for this for past several years. Second thing that we have already mentioned, or I have already mentioned, is that I do not drill any further than what has already been drilled by the endo. So if I make a root canal retreatment, I already have a huge canal. Of course, it is there, so it gives me more space. But if it's not, if it's a primary endo, then I just leave it as narrow as it was, and I only use that space given for placing endo-restorative material. I never use pre-drills in terms of enlarging the canal. I only use them to brush sideways the dentin inside the root canal, so I remove the damaged dentin, but I do not make the canal bigger. In the past, if you have some undercuts, you would have to remove it because you just couldn't fit the cast post inside, right? Today, undercuts are actually welcome because what they do is they enlarge the adhesive surface. And so undercuts give you hard time in terms of handling them, removing the caries, removing the loose dentin. However, if you can handle that, your restoration is actually better because you simply have more surface for adhesion, therefore a tighter junction between the tissue and the restorative material. And the fourth one, already mentioned, is the magnification. For modern endo, loupes are absolutely necessary. A microscope is even better. So whenever we do training, we bring in microscopes so people see things that they do not see normally if they don't have microscope at home. I believe that our restorative work gets way, way better with the microscope, though of course it's quite demanding for us as clinicians. Magnification makes us do things that would not be possible without them. I'm able to do this small, approximately 2 by 1.5 millimeter access cavity endo with successful completion of that root canal treatment. And that wouldn't be possible without magnification. So these 4 things do make my tissue reduction management plan. I try to minimize the defect I create to the tooth because there's already been defect made by a pathology, the caries or trauma, but I don't want to make it even bigger or worse just by drilling much more. And so you can see that in case where we needed to do endo, which is the right upper incisor, you see that I've made the endo through a remnants of dentin, which have been filled in with the resin composite before placing on the crown. We do not hide the tooth underneath the crown. The support, the abutment must be strong enough to support ceramics. If we shovel unclean dentin and unbonded composite underneath these crowns, what happens is the crown will start being loose, and being loose means cracking and destroying the crown. So longevity of the crown is also by the support of the abutment tooth. A second thing we have to think about a lot when talking adhesive is the damage done to dentin surface when leaving in this hypochlorite for these bubbly, nice procedures where you're killing the bacteria, which is very helpful. However, what you're left with is collagen-free dentin where its physical properties are greatly changed. It's only on a surface area. However, we need to deal with it, especially when we're using a more modern, later self-etching primers instead of classic etch and rinse adhesive systems, because you know that your adhesion depends on the quality of the dentin underneath. So what we do today is, before we do the adhesive process, we scrape away this whitish damaged dentin, and it makes these soft whitish chips where it's not a big thick surface. We're only talking maybe 50 to 100 microns. You are literally only lightly shaving away the damaged dentin. But with that, you can increase the strength of your dentinal bond to the tooth surface. Because we know that the adhesion to root dentin is a challenging task. It's even a chapter in a book was named like this by Alessandro Rice in the Jorge Perdigao book from 2 years ago, Restoration of Root Canal Treated Teeth. There's a whole chapter on that, discussing things that I also mentioned in the full day course, like what is the anatomy, how far deep you go into the root, because we know that the dentin is not similar when you compare crown to the cervical to the root. We know that the smear layer gets more difficult to handle the deeper you go inside the tooth. We know we damage the dentin with chemicals. We know we damage it by age, by chewing. We need to deal with adhesives and adhesive cements. We know that going deeper into the root makes light curing more difficult and longer. A large increase in C factor, the configuration factor, is again against simplicity of adhesion to root dentin. So when we want to adhere to the dentin inside the root, like we do to the crown, it's not that easy. These are scans from a case of mine many years ago, when this tooth been orthodontically indicated for extraction, and I previously made resin composite filling to it. So I had it sliced, and I see how am I doing in terms of adhesion to dentin. As you can see, the hybrid layer is well defined. It's holding up very well onto the collagen exposed by previous etching. And the whole thing is nicely put together. And this has been in service for about 2 years before extraction. And this is a crown portion of the tooth. Now, there's been 2 premolars. One of them was vital, and the other one was non-vital. And we took an image of the same patient, contralateral premolar, and this one was non-vital. And I've had a post about 12 millimeters into the root canal. And you can see there's a different dentin. There's a cement sitting next to the dentin, and there's a gap between them. So there is no adhesion. The composite only sits next to the dentin. There is no true connection. So it's not helping you much. Now the gap will eventually lead to more failure, more destruction of the dentin and of the hydrolytic procedure of the bond in the hybrid layer, more coronally to this. So from then, I realized we don't need to go all that deep. We actually want to go much less into the tooth. Let's stay up to about 8 to 10 millimeters from the surface. So we have a visual control, we have mechanical control, we have a good light cure level, and we have the surface made of more favorable type of dentin rather than going much deeper in the tooth. The videos, since we only have an hour, I did not want to include too many videos, and you can find them on my YouTube channel, and you can look at them in a full length, because 2 of them would make the whole lecture today. So this was the case in the video where I did a primary endo on a fractured tooth. It was there's been cracks in the tooth that caused loss of vitality. And here you see the 3-year postoperative healing taking place. Should we put in the post or not? Now, that's a good question and very important one. We know the functions of post-endo are sealing the radicular space, increasing the resistance of residual tissue, and supporting to final restoration. That's generally all the functions of post-endo. However, many of them will survive without a post. So why do we have the post for if we can do this? Well, there are cases where, like this one, you can just simply do adhesive reconstruction and post would have no meaning to it. A molar, you have a microscope, you can do endo through a small access cavity, you finish it adhesively. The only challenge is you need to put a right layers, because of course the C factor of that cavity is quite extreme. So you need some sort of a core cement. In my case, this is a high fill dual cure. Then you put a bit of a dental hybrid resin composite and enamel hybrid to make it nice and wear protective. In the later stage, past 5-8 years, there's been also a different kind than granular resin composite. And these are fiber composites, but not those fiber posts, but short fiber resin composites. That means instead of small round particles, we put in a small fibers. And these fibers can increase the strength of the tooth, especially in the molar area. So they prevent the tooth from cracking by occlusal force. In this case, it's a molar. I've added a bit more dentin composite to make that close cavity. And then I put 2 layers. One is the dual cure down in the bottom, having it nicely adapted to the floor. So it gives me a full adhesion down in the bottom of the cavity. And then I put a thick layer of these short fiber resin composites before putting on classic hybrid and of course a final restoration with a crown. So the layers are a bit different from the previous one. A bit of the dual on the bottom, but then the center of the tooth is light cured short fiber resin composite that has much more strength in terms of pulling action. Therefore, the transverse strength of the tooth is increasing a lot. There's been papers put out, and for me, despite the fact there's a crown on top, the crown will one day get loosed. You know, we lose crowns once, maybe in 15 years. But if the crown starts getting loose, I don't want to lose the tooth. So again, we want to fail it safely. We want to have it sealed. It's not the crown being the only resort of protection. We have several layers of protection before the bacteria gets back in the canal. So why do we actually have the posts? Why do we have posts for endorestorative? Well, the thing is, I think there's 3 uses of them. First, it's a pre-polymerized filler. It's already been polymerized. And if you can plug it in and take 60% of your space, that means the post will not shrink and your stresses on the wall will be lowered. Second thing, they create intracanal retention. So you bond yourself down in the root, but you need somehow to transform this strength into the crown. And so you put in a fiber post which is very resilient to the forces applied in a long axis of the fibers. And a third one, important one, is a scaffold. You put in the post and your restorative materials do not run away. They do not float because they stay around these posts. And I use that in molars quite often. So on a routine basis, my endodontic work would be like this. I remove the old crown indicated by a prosthodontist. I scrape away everything that's not a sound tissue. I redo the endodontics. I place in the post, the buildup, and I leave the tooth out nicely as an abutment, ready to be crowned, and allowing the prosthodontics to choose the preparation line. I'm not giving them a tiny small buildup. I'm giving them a bigger piece so they can decide how much they take away from the tooth. This is the case you've seen on the pictures where about 3 years follow-up of these two premolars is being followed. What kind of post do we have? Now, I don't even talk about that much anymore. It's always the fiber reinforced composite. My boy, who's now 3, when he was about 1 year and 3 months, he made this FRC with his letter in the garden. And of course, at that time, he didn't know how to read. He didn't know how to write, but he put these 3 letters together. And it was funny because this is my life a lot in science. I do a lot about fiber resin composites. And so when I talk fiber post, I mean fiber resin reinforced composite, usually containing quartz or glass fibers created into anatomical shape of different surfaces, different sizes. And the best ones on the market to me are those that have also some adhesive layer to it, so they are much easier to use in a clinical practice. 20 years ago, there's been a big discussion of what kind of post, and many papers put out what the post should look like. So at that point, we did not know much. Today, the knowledge about the fiber post is way, way higher, way, way better. Yet you can make a mistake. There's all the posts are not the same. So you need to know what are the physical properties, especially in the 3-point bending test results. You want to have those that last longer when bending, because we know the tooth bends. That's what happens. And so comparing the old solution and the new solution today, I think visually is important. So on your left, you have a classic cast post stuck in about 2/3 into the root. But for the smallest cast post, you still need to enlarge the tooth. And there's no adhesion. So, and it takes several times to do it because you need to prepare, you need to send it to the lab, get it back, glue it in, and then only after you can do the preparation for a crown. Whereas on the right, you see the tooth that has been treated endodontically, but then in the same session, in the same time, non-destructively, you use fiber post to encore the buildup inside that root canal system. But you don't need to go that far as with the old one. You can be much less deep into the root. Now, of course, it's a demanding task. It's not an easy thing to do. However, if you can do it well, your advances are great. Just like described, again, using one of the Didier Dietschy's papers where he's comparing the stress distribution between the cast post and the fiber post. And I think this is very important. The stress distribution in the fiber post is way different, and it's less destructive than the classic cast post. There's been a great discussion on should we use small post, big post, some kind of a direct anatomical post. Now, the differences are not big. to me, important is handle well what you choose to do. You don't want to be doing every day a different material and then a different post. I stick to the same materials for years and years, and that makes me master handling that particular case. So I can do even cases which seem hopeless or seemed hopeless 20 years ago. When I would see this, I would say, oh, extract it and put on a bridge or an implant. But today we restore teeth that have been greatly damaged, but we know how to do them correctly. And so you see these follow-ups, some of them for 2 years, some of them for 12 years. And we do have already a large record of these. As a matter of fact, yesterday I've had one of my doctorate students to go through a data of approximately 900 posterior cases that have been now clinically followed for 9 to 12 years. So we expect by early next year be put out a paper on one of those very long time followed large scale posterior adhesive restorations. So you see, in a cases like this, I need the post. I need something, some structure that goes for me deeper in the tooth and that takes up some of the volume instead of just putting all the shrinking material. I clean the dentin, I put in the posts, and I fill it around with the dual cure and then create this nice abutment tooth. So you have a case like this, where you can see that the damage to the premolar is quite large. However, the combination of dentin handling, adhesion, the right post, and followed by a nice prosthodontic procedure gives you a major advantage in restoration of endodontically treated teeth. Even cases where there's been much dentin lost from the inside, as long as you can handle the high C factor cavity by allowing the dual cure to set very slowly, then you can handle even those very difficult cases quite predictably. See here, I'm combining adhesion, pre-restoration placement of the hybrid, so I diminish the volume of those shrinking pieces. I put in the full post to take up some of the volume before placing in the final build-up for the crown. So you can see here, there's been a great damage done to the dentin from the clinical crown and from the inside out. Yet the predictability of this case is relatively good. Very important step, and I hope I still have some time. We started a little late, so I hope this will be okay. Dual cure workflow. Usually when you buy a dual cure, which many of us use to place in the post, it says, put in the dual cure, put in the post, and zap it with the light cure. Now, the problem is, there's been a few authors mentioning this. If you do this, you are not using the advantage of dual cure. You actually are creating much more stress by light curing it too soon. Whereas few papers, especially by Soares Verslus, they show that we have a advantage by waiting for the chemical cure to take place and only after that do the light cure. We know that our shrinkage stress will diminish by about 20% when doing so. So you do not lose any quality, but you make less stress. And this is good. This is very helpful. Only few papers been put out on this topic. And so I did an experiment myself by creating these 3D printed small cavities. It's like an MOD cavity, but it's just a cube. Each one of them have been filled First, they've been adhesively prepared by sandblasting and putting in resin adhesive. And then we put in, as a bulk, 3 different materials in 4 modes. Now, a standard for bulk filling is a Sure-Fill SDR. You probably know this name. It's by Dentsply. Sure-Fill SDR has been around for a while. It's kind of a flow material that allows you to light cure through it because it's quite easy to light cure through. Then we use the NSMHF, which is a dual cure with high level of filler load. If you can look on the right column, the filler load goes up to about 77% by weight. Now that makes it quite a filling. And then we took a classic hybrid composite, the light cure composite you would use for normal restorations. And what we did, we tried to have that dual cure immediately light cured or delayed light cured. So we had 4 groups. And what was nice to see, and what was of course expected, they all shrink somewhat from the sides. We measured how the 2 walls gotten closer to each other. And we know that if you look at that distance, having the SDR was very helpful, but having some other materials would give you similar results. So there's not much issue on making these 2 walls closer to each other. SDR or hybrid or dual cure would do pretty good job. But the big difference we found was in looking at the gap in the bottom. So down in the cavity, down in the bottom, when bulk curing this cavity, the worst results of all would have normal hybrid composite, that would be expected, but also a light cured dual cure. So if you immediately light cure a dual cure, you create a huge gap. And on the opposite side, the best results have been achieved by placing in the dual cure, letting it sit for 6 minutes, and then light curing. With that mode, we had pretty much no gap at all. It came out even better than the Sure-Fill SDR. So in our model, we knew that high C-factor cavity will be handled best by delayed light cure dual cure composites with high load of filler. See, on the left, you see the picture of this delayed light cure dual cure. There's no gap. It's all nicely touching each other. On the right, you see it SDR. In one of the failed cases, 3 cases out of 10 have failed. And then, of course, when you have a classic hybrid, you see a huge gap. Now, if you imagine a normal cavity, this gap is what makes your patient painful on chewing. If your new resin composite filling makes pain upon chewing, this might be the reason for that. And important, last but not least, who should be doing it? Endodontist or prosthodontist? And we've made the deal with Dr. Munajat many years ago, deciding that endoresto is endodontist work. But I see, traveling to the United States, that there's a big issue about this, and prosthodontists want to do the restoration themselves. However, this should be done by endodontists because we simply know better the inside of the tooth. I've already shown you the process we have, where the post-endo is placed in. And the cases are always the same. I take the tooth, I disassemble, I do the retreatment, and I also restore the inside, the abutment of the tooth, all in the same session. It's a single session, endo and post-endo. Prosthodontist with a crown comes later on, but the tooth is already restored. There's never a day without adhesive restoration inside that clean root canal system. So there's no chance for reinfection of the root canal system also. So when I say ideal endodontics, it means I disassemble, I reach the apical delta, I achieve patency, I do minimal transportation of the root canal, homogeneously pack that clean space, and then put in adhesive restoration with no bubbles, fiber post if needed, and adhesively creating that abutment to be followed by a crown. All of that is happening in a single session. On about 85% of the cases, it's a single session. Now, of course, if my root canal is bleeding or I don't have time, I have to separate into sessions. But normally, whatever the case, I complete them in a single session. I think this is very important from a clinical perspective as well, because, you know, it's, after all, we do that for a living. We don't want to have the same patient coming with the same 2-3 times. We want to complete that as soon as possible. So many non-surgical retreatments would happen like this. I would take the tooth. I would usually restore the adjacent teeth as well, do the retreatment, and do the adhesive restoration before somebody else comes in and places the crown on to complete the whole case. And so for me, post-endo is integral part of endodontics. For me, post-endo as an adhesive restoration of endodontically treated tooth is always part of the endodontic work rather than the prosthodontic work. And to conclude, I say about the adhesive post-endodontic treatment that it is a reliable form of post-endodontic treatment. To me, there's no competency problem. I don't use the cast post for past 13 years. We have very high level of success rate from these adhesive restorations. We utilize direct restorative methods, which means also it's it's something you preserve the time. It requires a visual magnification. You want to have good loops, your light or microscope at the best. However, it's hard to see in there without them. It simplifies your restorative workflow, so you still have that anatomy in mind before placing in the post. It is designed in relationship with the final reconstruction. So you making the abutment according to what's your prosthodontic work. Fiber posts are, however, only part of the problems, part of the restorative concept. We use different kinds of resin composite, from the adhesive, from flow, dual cure, hybrid, fiber post, short fiber resin composite. All of that is used to restore endodontically treated teeth. And the use of fiber post is indicated by the degree of tissue loss. So the more tissue loss, the more likely you place in the post. And with that, I thank you for your attention. If you want to look at the videos, I have been made to skip because we don't have that much time. Just take a look at my YouTube channel. I do post some of the cases on Facebook or Instagram as well, but YouTube has some nice videos that you can watch for as long as you want. So thanks again for the invitation. I hope this was not much fast, and I hope there'll be some questions about it as well. Thank you again for the invitation.
Dr. Daniel, thank you a lot for this great lecture. It was specific and scientific methodology. You mentioned about putting composite dual cure on the pulp chamber. Yeah, I was mentioning that you put dual cure on the pulp chamber, then you use the fiber resin composite.
Yes.
Then the conventional composite. Yeah. Dr. Omar Hamada is with us now. Dr. Omar Hamada, you can start the questions.
Okay. Dan, thank you very much for this elegant presentation.
And the discussion, and I will pick some questions from the media.
Great. It was really very simple and very informative. First of all, please, I've got just a quick question, if you don't mind. What about the cutoff point? You spoke mainly about the fiber post in your presentation, but what about the cutoff point between using casted post and fiber post? Because from the restoration you have been presented in your presentation, there is no impossible with your restoration with using a fiber post. It seems you are able to place 2, 3, 4 fiber posts, and you ended up with very nice restoration. So just if you could explain this point for us, please.
Well, we don't use cast post at all, because the thing is, the need for cast post have been augmented by lack of isolation. So in a molar, maybe somebody has an issue of placing the rubber dam correctly. And second, they say that if you cannot do a proper crown design, then putting in a strong post like metal would help you to support the crown. However, I've been lucky. I have these two great prosthodontists with me in a practice where we have a deal that there's never less than 1 millimeter ferrule in a crown. So I know how to isolate properly. And it's been a while before making the deal with how to isolate using retraction cord and rubber dam and all of that. However, today, 100% of the cases I complete is done adhesively. We haven't done a cast post since 2006. And so for me, there's no way back. There's no way to do anything else but adhesive restoration.
Okay, thank you very much. Another two, let's say two technique or two method regarding using the suggestion about using the main post and in some situation using as well the auxiliary post. What do you think about it? Well,
first, a post means retention inside the root. If you have a molar that is basically grounded all the way to the gum line, and you need to gain some adhesive surface, I use fiber post to hold into the root system. And we know that the quality of the adhesion down in the root is worse than what's up in the crown. So if I have that molar, and I know that I need to get as much retention as possible, I pretty much choose every space where I can place the post. And I wouldn't call them a main and auxiliary. They all posts that fit into that particular canal. So if I have 4 holes, I put in the 4 posts. I don't pre-drill. I do not take away sound denting in order to place a post. But if there's a hole and I can fit in a post of particular size, then I use that. And so in some cases, there's been 4 posts, but many times today for molars, there's no post at all. It's only the dual cure and the short fibrous and composite, because you still have some tissue left and there's no retention need. However, if there is a retention need, then the number of posts is limited only by the number of spaces given.
Okay, so regarding, for example, if we have a novel canal,
yes,
what's your recommendation? And at the same time, when we are putting, let's 3 or 4 posts, are we sacrificing with a good amount of tissue?
No, at all. If you have an oval canal, you basically look at the proportions. If it's and classically, this is a premolar, upper 5 we all know they make sometimes this 3-to-1 ratio of oval. What do you do? Well, you simply put in 3 small posts. So you do not increase this dimension in order to make a big one. You use that narrow area, but use 4 posts sitting next to each other, and they may be all of the same size. And the meaning of that is I just simply take more volume of the shrinking composite and put in something that's already pre-polymerized. Now, of course, the argument might be it's more expensive because each one of those posts cost, I don't know, maybe 8 euros. So when you put in 3 of them, it's quite costly, but still, no matter how many posts I put in, it's still less expensive than taking an impression, sending it to lab, putting it again. That would cost 200 euros instead of 20.
Okay. Before I ask you my last question, I'm very happy and pleased to let you know that we have about 3,500 followers of your interesting presentation.
Thank you.
So my last question actually would be about what we now, maybe like a company like RTD, it's produce what we call adapted post. Right. What's your experience about it? Do you recommend it?
Well, see that there has to be a discrimination between what is marketing and what is science. Now, RTD has a great record of making awesome products on post-endo since the 90s. They've started with the carbon post already. We all know these papers by Marco Ferrari back in the 90s, large-scale clinical works. This is of course something that this producer is the leader in the world. However, the rest is much of a marketing thing. I think that we can call it different way. There's been adaptive. There's been somebody likes to have that stepping design. To me, important part is the internal structure of the post. And this is something none of us will be much able to understand because it's very complicated. And the producers do not let it out much happily. Of course, we tend to chop it and measure and see how they're doing. And I think this in the post, what is important is, again, the internal structure of the post. So the better you fit all the fibers and glue them together with the matrix, the better the post. The problem with many posts is that if you damage the surface, if you have some kind of a shaping on that, you get more fluid inside that post, and when the fiber post soaked saliva or liquids into it, it becomes softer. So to me, the best possible post is the one that nicely, loosely fits inside the root canal system. If you touch it too much to the wall, if you do not wrap it around in the resin composite, then you have a problem. If your post is open on the upper part and you have water or seepage into the post, you have a problem because it becomes softer. As long as your post is covered inside, is protected from excess of water, and the internal structure is bubble-free, well adhering to each other, then it's a great post.
Okay. Before I move to Dr. Anas, I have to admit that I do agree with you that the person who be able to, or it's better to restore the tooth after the endodontics treatment is the endodontist. It was a great pleasure, Dan, to having you here in Damascus University. I really enjoyed your presentation, and I leave you with Dr. Anas for some comment and
Yeah, Doctor,
thank you very much, Dan.
Thank you.
Thank you, Omar.
Thank you a lot, Dr. Omar. I'm very happy today to be with you and with Dr. Tchierny. I have some questions from the social media. The first question is, I noticed that in the premolar, in the first of your lecture, it has missed maybe the mesial wall, I think. During reading Torben Jab book, he mentioned that in the dodically treated teeth, it's missed a wall, so we should cover the two cusps, which is close to the missed wall. You made an advice why the filling composite could be enough. How could we avoid the fracture so in the future?
Yes, of course, in a short lecture and on two pictures, it's hard to explain the whole case. As a matter of fact, analyzing the case, it takes probably several hundred of factors, and many of them are related to how much dentin there is left underneath the cusp. It doesn't matter much how big defect is on my proximal wall, because it's still just one proximal wall. If I have the other one, if I have the underlying dentin in the cusp, so the axial is damaged, the proximal is damaged, but then the cuspal dentin and the other proximal is still there, and it's strong enough, then that's a first condition to follow. Second thing, I'm looking at the occlusion of that particular patient. If he's a bruxer, I wouldn't dare to do this. But if there's a well-restored teeth around, if there is no sign of bruxing on that particular patient, then I would go with that direct restoration. Now, honestly, this doesn't happen too often. Usually this only happens when I happen to be treating a primary caries. The majority of the cases, we do place in some crown, because the loss of dentin would simply be too much.
Yeah, that's a great clarification. The second question is about, do you feel that there's a difference while the fiber post is tapered like a bone or cutted of the tip, whether it will be flat or pointed? This is a question from
I do have some issues with that signal, but let me start with that first part of your question.
Is it matter that the tip of the fiber is flat?
Yes.
The signal is better now. Is it?
Yeah.
Yeah. The question is about whether the fiber post is pointed or flat.
Yes.
Tip.
I think that it doesn't really matter that much. The deeper you go, the less important it is what the shape is. What is important to me is then before I place in the post, I put in the dual cure, and I'm making sure there are no bubbles inside of this, because of course bubble means there's no adherence. So I place in the dual cure, and then I put in the post, and the post must fit loosely. Camillo D'Arcangelo has put out a paper stating that the best adhesion is achieved when there's at least 200 microns on each side. Now, of course,
they call it the wibbling test. They call it the wibbling test. That means the post could be wibbled a little bit inside the canal.
Exactly. And so at the end, if you have a tip, or if it's rounded, I don't think there's much difference to it. You don't want to have this bonding when you just test dry your post. You don't want to have it stuck in between the walls. It must be a little loose, like you said, the wobble test.
Yeah, continue to this question. Dr. Saeed Al-Adib, who sent the question, is asking whether we should put the fiber post close to the missed wall or the wider canal or the functional cusp. What do you prefer if we do, or if you use one fiber post?
Yeah.
The missed wall, the functional cusp, or the wider canal?
If you have a defect, I tend to use the post on the side of that defect. So if you have a molar with mesial cusp still present and distal would be destroyed, I would post the post in the distal one and have that as a support. So basically I'm following where is the damage. Now, of course, ideally, instead of one post in the center, would be better to have a 10 post around the surface, because it would create a 3D structure. But that's literally impossible to make inside that root canal.
So the other question is, do you use Nayar core in composite? So, for example, you mentioned in some cases that you don't use the post, you fill all the pulp chamber. Do you let the composite go inside the canals 1 millimeter or so, like?
Yes, exactly. I always go somewhere to the level of alveolar bone. So I use up all the pulp chamber for adhesion. I just don't go any further into the root when it's not needed. In a molar, if you still have some lateral walls, like the one behind me, you see there's a molar with still buccal and palatal walls present. So you don't need a post for this one. You only need to start down in the chambers, and you can actually see this right here behind me. The palatal would be probably ready for a post, but the distal and 2 mesials are just as they will be used without the post. And so I'm just using as much surface as possible without entering too deep into the root.
Yeah, so you are trying to get a more surface for bonding, for retention. But I have a question here. There is some cases really was brilliant. 2 or 3 cases about all the tooth is knocked down. You maybe have foreign effect like 1 millimeter. We have always a dilemma. Should we use the cast post when we have a foreign effect of 1 to 2 millimeters? Or we can go with fiber post, one only fiber post, or we have to put a fiber in each canal?
Well, see, again, the more
I mentioned, the question is, you have cases that foreign effect, the foreign is 1 millimeter or 2 millimeters maybe. Either you should use, or what's your advice? Either to use a 1 fiber post, even with this small ferrule, or a fiber post in each canal. Why don't you go with the cast post, for example?
Well, I already said there's no case where I would aim for cast post instead of fiber post or instead of adhesive restoration. There's no advantage at all. As a matter of fact, imagine there are cases where you have some kind of undercuts, where you have a complexity of the pulp chamber, and placing in the cast post would be always more complicated than using the adhesive. With the adhesive, I can go around, I can go in a hole, I can go in the undercut. All of that can be achieved with adhesive dentistry better than with the cast post. So then, of course, I calculate in my head how much surface for adhesion I have. And if it's sufficient, I don't use post at all. If it's not sufficient, I take 1, 2, 3, whatever is available and whatever is necessary.
Really, that sounds great. For clarification, I have a last question. Maybe I feel Dr. Omar Hamade maybe has something to say. Oval or very wide canal. Do you prefer to post or to put 2 fiber posts? Then we'll do the rest. Oval canal, wide one, or sometimes in the premature tooth incisal, it will be wide. Do we rely on the resin which filled around the post, whatever it's wide, or we should add another fiber post in H-shaped canal, for example? What's your advice to the audience and the colleagues here?
Okay, if it's just a little wider, then you just shorten the tapered fiber post, so you make it bigger. You simply tip away the 3-4 millimeters, and all of a sudden you have it bigger. If it's even bigger than that, then I don't take the biggest post. I take a smaller one, and I take 3 of them. So I just create a whole bunch that has to be nicely covered with the dual cure. But I place several smaller ones, because if you place a big one, you may have a struggle to put in another one next to it. But if you take 3 small ones, they'll fit nicely in that round canal.
I really want to mention something. Once you put 3 fiber, could the retreatment will be something very hard in the future, for example? I noticed that the root canal treatment that you do is brilliant, really. You are a great endodontist. But sometimes we can think that in a little curved canal, you see, we will put the fiber post, we will have small ledge here. What you advise, and then we will go to Dr. Omar Hamadi to make a conclusion. Yeah.
I would show you a case.
Yeah.
Any fiber post you want to remove, and you have a microscope, does not take more than 5 minutes to remove. You have a proper drill, you look in there, and you start drilling through it. As a matter of fact, the fiber post allows you to follow the post very safely into your root canal system. It's much easier to remove fiber post than to remove a cast post.
You're talking is great about when we see what we are doing, everything will be safe. That's right. I agree with you immediately. When we can see, I tell my colleagues and students the comparative situation between when we have microscope and we don't have. It's the same as blinded people. They can sometimes walk in the street and know the home, but how difference could we reach if they can see where they are? Thank you, Dr. Daniel Tshirni. Thank you for all you do. Thank for Dr. Rashid Al-Najid as well. Maybe Dr. Omar Hamadi will conclude at the end of lecture. It's highly appreciated that I am with you and with Dr. Hamada making the discussion. Thank you.
My honor.
Thank you, Dan, very much again for the nice presentation. And please deliver my greeting to all members of DCM and as well for the people in HDVI. And it was my pleasure actually to give some presentation with you as well. So hopefully we can see you again on Damascus University website, the dental school.
Thank you very much. Thank you very much. It was a pleasure. Thank you.
Have a nice weekend. Bye for now.
You too. Bye-bye, Omar.
Right. See you later. معنا حقيقة بهالمحاضرة القيمة للدكتور دان تشيرني من جامعة أولموك بالجمهورية التشيك. حقيقة عرض تجربته هو اندودونتيك لفترة طويلة. الشيء الجميل اللي عرض التجربة تبعته بالترميم. حقيقة أنا اتفق ليرمم أيسن معالج لبيا هو الشخص اللي عالج لبيا، لأنه هو الخبير بالسكرت بالقناة، الأقطار تبعتها، الأطوال تبعتها، فأقدر يعرف وين ممكن ينحط وبيقدر يفرق المناسب دون ان حقيقه من الشغلات اللي ذكرها ايضا انه هو بيفضل، طبعا حكى حاولنا نساله امتى بيكون الحد الفاصل بين استخدام الكاست بوست والفايبر بوست، حكى هو من 2006 لهلا ما استخدم اي كاست بوست. الفايبر بوست عم بيحل له كثير مشاكل بغض النظر قديش في عندي تهدم، ما عنده مشكله يستخدم up to 4 بوست فايبر بوست، شفتوا حطهم. بفضل لما سالناه شو القناه الانسب لاستخدام الفايبر بوست، فهو حكى انه القناه الاقرب للجزء الاكثر تهدما من السن. الشغله الاخرى اللي ذكرناها بالنسبه لشو وضع القناه او شلون بيحب يكون التحضير بالنسبه لتلقي الفايبر بوست، فهو بفضل ما بيحب يكون كثير تايت بقلب القناه، بنفس الوقت ما يكون لوس او متحرك بشده، هو فقط في حركه جدا خفيفه ليسمح للسمنت لياخذ كميه سمنت كافيه ضمن القناه. بفضل يستخدم الدول كيور سمنت فيهم. وفي كثير من الحالات عرض استخدام عده انواع من الترميمات اللي هي دول كيور، اللي هي فيها لايت كيور والفايبر كومبوزيت للترميم. تقريبا هي معظم الحالات يلي والامور يلي قدر الدكتور دان تشيرني لخصها بمحاضرته. شكرا كثير لكم ولمتابعتكم، ودائما تموا متابعين لقناه كليه طب الاسنان بمحاضرين مميزين بالايام القادمه. مره ثانيه شكرا لعماده كليه طب الاسنان لهذه الفرصه العظيمه، شكرا لمن ساهم باعداد والتواصل مع الدكاتره، شكرا دكتور أنس، شكرا لحضوركم، شكرا كثير.